Hello guys, am I audible and visible? If so, just give me a thumbs up so I'll be able to know that and we shall continue it. Fine. So hope I'm audible and visible. Okay. So a very good evening to all. So this is a study with me series. Today we'll be having in next 4 days exactly at 5 p.m. we'll be having discussions on RBCs and WBCs. I'm going to take a topic in particular and discuss something in detail about the same topic. And then what you're going to do is you're going to also see MCQs in the Unacademy app on the same topics, right? So we'll be basically discussing about RBC and WBC disorders. First 2 days will be RBC disorders. This will be the goal for us. So today 5 p.m. will be RBC, tomorrow will be WBCs, so tomorrow also RBC, sorry, and Wednesday and Thursday we'll have a quick look about WBCs, fine. So I will be talking about iron deficiency anemia primarily today and few things as well in addition to it. So if you want anything in particular in WBCs, do let me know, we can cover them as well. There's going to be an in-detail discussion and it will be followed by MCQs in the Unacademy app, fine. So hope this will be of help. So if there is no other queries, we shall go on to the topic straight away, right? So as you can see, today I'm going to talk about primarily about iron deficiency anemia, right? So when you take iron deficiency anemia, how you're going to divide iron deficiency anemia is, in our lectures today, we're going to talk about few things here. So to understand about IDA is a very important topic for an entrance exam. There are few instances where AIMS had 3 or 4 questions only on iron deficiency anemia. So we'll try to cover everything from the basic absorption of iron, the metabolism of iron, the function, the phases of iron deficiency, how you're going to diagnose them, the iron studies, how to easily remember iron studies, and everything regarding iron, right? So we'll be dividing the topic into iron absorption. That's the first thing we'll be discussing about. And the utilization of iron. See, most of the time what you must have done is we must have read about iron absorption, and then what you would have gone through is we would have directly gone through the that it has been utilized in the RBCs. We will be seeing how they'll be utilized in the RBCs, the transferrin receptors, the metabolism of them in the erythroid as well, fine. So we'll have a quick look about utilization as well, fine. Then we'll look at the deficiency states, because when you go and look at the deficiency state, I can have from the commonest deficiency of your nutritional deficiency till you can have your genetic deficiency as well. DMT1 deficiency can be there, TMPRSS1 deficiency can be there. So we'll have a quick look about them as well, fine. So obviously our goal is for diagnosis. Before diagnosis, like for any other disease, we'll look at the quick look at the metabolism. There are stages of iron deficiencies, negative iron balance, then an iron deficient erythropoiesis and iron deficient anemia, right? We'll look at the pathogenesis, then a quick look about the clinical features. So I'm sure you know that I will not be talking much about the clinical features. My forte is going to be the diagnosis in the lab. So then we'll look at the CBC values, we'll look at serological values, iron studies, not just restricted to the 4th thing. We'll look at what is an serum transferrin receptor, which came in an ACT recently, INACT. We also will have a look at your free erythrocyte porphyrin. That might also be required for you in future if any questions come on that. And again, a quick look about my treatment, right? So as your clinical diagnosis and treatment, I'm not going to mention in detail, but what I'll be seeing is the follow-up of the treatment. See, because when I say about the follow-up of the treatment, that also is based on my lab diagnosis only. Every patient of iron deficiency anemia will have a certain test to be done in certain intervals post-treatment to look at the response to the treatment. If my response is good, if my response is poor, what I'm going to do. So those are things which we'll be covering in today's class of iron deficiency anemia, fine. And if time permits, we'll look at the other things as well. First, we'll go and start with basic things about iron absorption. I'm sure you must have read about iron absorption, right? So if we have to start asking few very simple questions, what are the which area of the intestine iron will get absorbed? That's a very, very simple one. Which area of intestine do you think iron is absorbed predominantly? It is duodenum, right? So iron gets absorbed in the duodenum predominantly, fine. Just a second. Okay, fine, sorry. So iron gets absorbed in the duodenum properly. So what are you going to look as just a basic thing about iron absorption. The site of absorption of iron is duodenum. Iron will generally be absorbed in the Fe2+ with the help of a transporter called as divalent metal ion transporter, right? So let's assume this is my duodenal epithelial cell. Okay, I'm going to have a dual epithelial cell like this. I'll have a metal ion transporter here. We're going to name it as DMT1. It's divalent metal ion transporter. With the help of the transporter, the entire ion molecule is going to come into the duodenum. Fine. So let's say Fe2 plus. DMT stands for divalent. So when I say divalent, it's not only going to help in the transport of your ion alone. Any divalent metal will go via this transporter. It's going to go inside, right? So my divalent metal ion transporter, with the help of that, let's assume that ion has gone into the duodenal epithelial cells. See, the absorption of iron is totally need dependent. It's not like any other nutrition, like I'm going to eat it, my body should absorb it. It's never like that. Only when there's a requirement, iron absorption will go into my serum or in the blood. Otherwise, they're going to go into the physiological form of ferritin. It gets stored in the same duodenal epithelial cells itself. Fine. So what happens? Immediately after absorption, it goes and gets stored as ferritin. So once it's getting stored as ferritin, this ferritin will release iron only when my body requires it. If my body is not requiring iron, it will stay as ferritin and it will die and it will be excreted along with the death of duodenal epithelial cells, right? This I'm going to call it as a mucosal block phenomenon. The excretion of iron is only via my duodenal epithelial cells. Otherwise, whatever I'm going to have in the RBC will automatically be reutilized, right? So what I'm going to say is, if my body is not consuming them, or let's say it's an excess ferritin or an excess iron which I'm absorbed, I don't need that. What happens is, this excess iron will be lost when the duodenal epithelial cells dies. Okay, so along with the duodenal epithelial cells death, it will be completely lost, right? So my entire absorption, the dynamics of the absorption is maintained by the mucosa of the duodenum. This we call as a mucosal block phenomenon, right? So if my body requires iron, what will happen? So if my body requires iron from ferritin molecules, it's going to go outside again. Again, I cannot just like that go. I need a transporter here, right? Here also I need a transporter. The transporter here, what I'll be requiring is ferroportin. Okay. So with the help of ferroportin, the iron goes outside. Fine. Once the iron goes outside with the help of ferroportin, it's a free iron. It's in the serum or in the blood, right? A free iron cannot be left just like that in the blood or serum, because we know that free iron is capable of creating free radicals. So what I'm going to do here is, this iron here will be bound with a transport protein. It will bind with my transferrin or apotransferrin, the precursor form. Okay. So once it binds to my transferrin, it's going to be carried to my erythroid. It will be carried to my liver, and also few of the, let's say, the enzymes which requires iron, it will be taken to those cells. The predominant person who's going to consume iron is erythroid only. Fine. So from the transferrin, let's assume this is a transferrin and I have iron here. This will go to all the places which require iron. Enzymes will just ignore for the time being, because that's not the predominant utilization of iron. But I want to read in detail about how iron is being utilized in my erythroid. At the same time, how iron is being utilized by my liver as well, because both these erythroid as well as liver will have receptors for transferrin. Fine. Okay, so this is going to go to two main locations. One is erythroid, the other one is liver. Okay, because both of these guys will have transferrin receptors. The utility of iron and transferrin receptors is totally different in erythroid and liver, because liver has no role in utilizing iron. So why does liver have iron? Is the transferrin receptor is to maintain the feedback mechanism, because liver is a regulator. Liver helps in the metabolism, it helps in my iron metabolism as well. Fine. So look at the erythroid. What's going to happen is, okay, we'll look at the erythroid or my bone marrow. I'm writing BM for bone marrow. See, let's see what's going to happen into my normal erythroid. If you remember your erythropoiesis, one more question which can come is, which is the stage of erythropoiesis where you will have your hemoglobin formation? There are two MCQs based on that. One is hemoglobin utilization, other one is hemoglobin formation, right? Two things here. Hemoglobin will be formed when my very pro-erythroblastic stage itself, right? Hemoglobin will be utilized or visualized in an intermediate normoblast stage, right? So what happens is, when the transferrin with the iron goes into my bone marrow, this is what is going to happen in my erythroid. Let's say in my pro-erythroblast stage itself. Okay, in the pro-erythroblast stage itself, what's going to happen is, I'm just drawing an erythroblast in a very big way so that we can understand exactly what's going to happen here. Fine. So I'll have here transferrin receptors on the surface. Fine. These are the receptors of transferrin, where the transferrin along with the iron will come and bind. Okay, so once it comes and binds, it will be internalized. Right? This automatically goes inside, it will be internalized, and iron will be utilized. Once the iron is utilized, the transferrin receptor goes back to the surface, and because it will be endocytosed, it will be utilized, and obviously the transferrin receptor will go back to the surface. My iron will be utilized in the formation of hemoglobin, transferrin receptor returns back. So sometimes what happens is a domain of transferrin receptor which will be excreted. That's, I'm going to call it a soluble transferrin receptor. These transferrin receptors here are membranous transferrin receptors. Fine. Once I'm going to use them, a little bit of transferrin soluble or my serum transferrin receptor, it's also a protein of my your surface receptor only, but it's broken down and gone outside. Fine. So the amount of the membrane transferrin receptor is equal to, it's going to reflect the amount of my serum transferrin receptor as well. Fine. I'll rephrase it again once again. I'll come outside, and this transferrin receptor, once is utilized, a part of it will be excreted into the serum. See, because this is very important for me to diagnose few diseases, especially the difference between anemia of chronic disease and my iron deficiency anemia, which once came in an exam. Fine. This I'm going to call it a soluble transferrin receptor. Okay, it's my soluble transferrin receptor, or I can call it a serum transferrin receptor. Okay. So in other words, it's based on the recycling mechanism. If my body is able to have lots of transferrin and utilize lots of iron, the amount of transferrin receptors on the erythroid will increase. At the same time, the amount of transferrin receptors in my serum also will increase, right? These both reflect each other. Okay. More amount of serum means, or a soluble transferrin receptor means, more amount of receptor is there in my RBC or my erythroid also. Fine. This is what happens in my erythroid. Okay. So obviously my erythroid, once it is able to put the iron into the hemoglobin, it helps in the formation of function of RBC. RBC, after its lifespan of 120 days, it's going to go back to my spleen, because every deformed RBC is going to be destroyed in the spleen. That's why we call it as a graveyard of RBC, right? So let's say that a perfectly formed RBC has been there due to the hemoglobin, and this RBC, after it crosses its lifetime, let's say after 120 days, it will be phagocytosed in the spleen. Once it's phagocytosed in the spleen, it's going to, we are going to call them a littoral cell, right? The splenic macrophages are called as littoral cell, and it goes back. Let's assume there's a macrophage, a nucleus, and let's say this is my broken RBC. See, by RBC is being broken inside the cytoplasm of spleen. So what happens is, it's hemoglobin. Heme and globin will be reutilized. It will be split. Globin will be reutilized. Heme will be broken down to bilirubin. So what happens is, the iron which is there, which is unutilized, right? Iron cannot be in free form, and iron cannot be in the macrophage. So what happens is, after giving up globin, after converting heme to bilirubin, the iron which is left inside here has to come outside. For coming outside, again I have a receptor called as ferroportin. So ferroportin converts my iron from the macrophage outside. Again, where does the iron go is, it's simple. It goes to my serum pool again. Which means when my RBC dies inside the body in spleen, I don't waste any iron. The only way iron gets wasted from my body is from the duodenum. From the mucosa, once it dies, it goes away. Fine. So this goes back to the serum pool. It's been reutilized. It goes to transferrin. Again, get utilized in erythroid. Fine. This is what happens in my erythroid. As I said already, my liver also is a major component of transferrin receptor. Why do I need transferrin receptors in the liver, and how I am going to use it for my metabolism of my iron, to regulate the iron metabolism? Fine. So let's say that, let's assume my liver has transferrin receptors. The same way, these receptors. Some of the transferrin comes and binds here. Fine. It's not the same equivalent amount of what binds to the erythroid. A little bit about that. This function here is to know that, okay, if all my transferrin receptors in the liver are bound with iron, I'm going to give an information to the liver, the amount of iron in the body is too much for comfort. I don't want these many. Right? So if these receptors are full, my liver gets an information that I have to reduce iron absorption or iron exit to my serum, right? Reduce iron exit to serum. So what it does here is, it produces once the transferrin receptor has reached a threshold in the liver surface, it's going to release a product called as hepcidin. This came in an MCQ once. I'm sure you guys know that hepcidin is an master regulator of iron metabolism, right? So what this hepcidin does is, it's going to do only one thing. I'm just going to zoom out a little bit so that we can understand clearly. It's going to have an inhibition effect on these two ferropotents, right? It'll have a negative feedback on ferropotents, right? So iron metabolism is kind of clear, right? So in other words, if the same liver's transferrin receptor is not full with transferrin, which means the information to my body is, I don't have enough iron in my serum. So the amount of hepcidin will reduce. So the negative feedback will be removed. So ferropotent will transfer more iron into my serum, right? This is a regulation. And hepcidin is the master regulator of iron metabolism. That's an MCQ as well. Okay. So this is what happens in normal iron metabolism. We'll have a quick recap and then we'll go to the disorders. Iron comes into my body. I eat the food. We have heme and non-heme iron. We'll see them sometime later. Where DMT, when it goes inside, stores as ferritin. When my body needs it, ferropotent will be activated. The person who turned on ferropotent is again hepcidin. So how I know my body needs iron is, my liver has transferrin receptors. If they're not enough full, I know that there's defect in the transferrin or my reduction in the serum iron. So I'll turn off hepcidin, ferropotent will open. So everything will come outside. It will bind to transferrin and goes to the erythroid. Once it goes to the erythroid, the surface erythroid, in the surface I have transferrin receptors. They'll bind to them and will be utilized, right? And after utilization, the surface transferrin receptors breaks down and go to my serum. We call them soluble transferrin receptors. After incorporation to the RBC, 120 days later, that will die, phagocytosed by the littoral cell. Littoral cell also has ferropotent receptors that will push my iron back to my serum, fine. And all these are regulated by hepcidin. Right? This is normal iron metabolism. Once I know normal in detail, it's easier for me to understand the abnormality, fine. Now our main goal is to understand about iron deficiency anemia, right? Zoom a little bit. Okay, let's take a look about IDA. So when you have iron deficiency anemia, for every disease, what we're going to have is, we'll have etiology, we'll have pathogenesis, we'll have the way to diagnose clinically, lab-wise, and treatment, obviously. So first, we are going to look at the etiology. So when you look at the etiology of iron deficiency anemia, I have multiple causes. The predominant cause is going to be dietary deficiency only, right? So I have multiple causes of iron deficiency anemia. First, we'll go look at the etiology of iron deficiency anemia. The predominant etiology being your nutritional deficiency only. I'll look at the genetic deficiency later. They are very, very rare. So predominant is going to be nutritional deficiency. Apart from that, I can have an increase in blood loss, because once blood is lost, obviously hemoglobin and iron will be lost as well. I can have malabsorption. If I'm going to have an celiac disease affecting the duodenum, I can have a problem, right? Duodenal villi gone, all these things can collapse, right? If you have a gastrectomy with proximal duodenum gone, again the site of absorption is not there, I can have a problem. Again, those are rare, but dietary deficiency becomes the most common, followed by increased blood loss, right? Or my increased physiological demands during pregnancy, infancy, lactation. Those times I can have an iron deficiency, and few other causes we'll have a look. I can have an increased blood loss. Again, this increased blood loss can be it could be an acute blood loss, might not cause a problem. Most likely which will cause iron deficiency anemia is a chronic low grade unnoticed blood loss, like an occult bleeding, or could be a menorrhagia, because menorrhagia can lose good volumes of blood and treatment sometimes might not stop it, right? So all of them are possible cause of increased blood loss, right? So one is menorrhagia. Apart from menorrhagia, I can have a chronic and an occult blood loss. When I say occult blood loss, it's either the stools or the urine. I'm not able to see it, but slowly it goes away, fine. So in chronic occult blood loss in the stool, most likely. Two things comes to mind, top of the mind for chronic occult blood loss. One, in children, worm infestation. Ankylostomata duodenale, Necatora manicaris, it loses supposedly 0.25 ml per day. Very, very tiny. But it's going to be there for years together. So years of blood loss, slowly it might cause anemia. The next important thing, this comes in an MCQ, not just in MCQ, in your real life as well. Because a very, very common finding seen in your real life as well. In elderly, colon cancer. Keep this in mind. When you have any question which says that a person is 70, 80 years old, a very, very elderly person, right? 70, 80 years old person having iron deficiency anemia, that to a new onset, think of an occult blood loss in the stool. See, because till that 60-70 years, the patient is not having any problem. Do you think it will be due to a dietary deficiency? Unlikely, right? It might not be due to dietary deficiency, right? So you have a colon cancers. In colon cancer, you'll have an occult loss in the stool. This occult loss might be unnoticed. So if you have an elderly with an IDA, the first possibility or the next step you have to do is do a colonoscopy. This has come previously in exams, so you have to know about it, right? Colonoscopy is a way to see if there's any problem in the colon. If there's any problem, take a biopsy and take care of that, right? So I can have other forms of dysentery having, peptic ulcer, hemorrhoids having, amoebic colitis, but again, those are all treatable conditions, so I might not have a chronic loss, but these two definitely are known cause of your iron deficiency anemia, right? Then have an increased requirement, increased demands, especially due to pregnancy, lactation, the most important thing, and adolescence, infancy and adolescence also, where the person is going to consume lots of them in the growth. It can be a problem as well. Okay, that's the reason we generally try to replace the increased physiological demand by giving 100 iron tablets to every pregnant woman. In spite of that, I have few problems, fine. So these are all the causes of an iron deficiency anemia. So my body has got deficient iron. How is my bone marrow going to react, and what are the changes which are going to happen in the bone marrow sequentially, stage wise, right? Before understanding that, because these 4 stages, there are 4 stages of them, we call them just the stage of iron deficiency. Before knowing that, because all these 4 stages are based on only one finding, which is your iron studies. It's based on iron studies only, because in few of them there will be no problem in the iron stores. Few of them iron deficient erythropoiesis will happen. Few of them only transfer saturation, those things only will change. So to understand about the pathogenesis of my iron deficiency anemia or the stages of iron deficiency anemia, we have to have a quick look at iron studies. Fine. Because knowing about iron studies will make us clearly what's going to happen in these patients. Fine. So there are many things in iron studies. The common denominators are my serum iron, ferritin, total iron binding capacity, your transference saturation, and RBC protoporphyrin, because that's also included in the stage of iron deficiency, so I'm including that as well. Fine. So what I'm going to see in iron studies is we're going to name serum iron, serum ferritin, you have transference saturation, we have your total iron binding capacity. See, TIBC is total iron binding capacity. The way I want you to remember everything about TIBCs, it's just affinity of binding. Let's say it's the affinity by which a transferent will bind to iron, that is TIBC, fine. And we have few more guys, RBC protoporphyrin, the free erythrocyte protoporphyrin, fine. These are few newer terms which might come in upcoming exams, right? And also about soluble transferrin receptor. Soluble transferrin receptor has come recently in the INCT exams, fine. So you have these 6 things. First, look at the first 4 because they are interlinked. The RBC protoporphyrin and serum soluble transferrin receptors are totally different. We'll look at them as well, right? So let's see. I don't want you to memorize these. What happens in IDA, what happens in anemia of chronic disease. If you understand what is the problem, we automatically can extrapolate what happens in your anemia of chronic disease or in your IDA or in your sideroblastic anemia for that matter, right? So I'll take serum iron. Serum iron is a straightforward finding. It's the amount of iron present in the serum, right? So if iron is present in the serum, who will the iron bind to? It has to bind to only one person, transferrin, right? So these 2 things should be linked. If I'm going to have, let's assume that transferrin has 5 sites in which iron can go and bind, and my serum molecule has only 1 molecule of iron. Do you think the 5 sites will be full? No, only one person is going to be full, right? So if I have 25 iron molecule and only 5 sites are there, do you think everything will be full? It will be full and it will be saturated. So in other words, when serum iron is less, what will happen to saturation? It will become less, right? So these 2 guys here are directly proportional. Okay, these 2 guys here are directly proportional. More the serum iron, more is the saturation. Less the serum iron, less the saturation, right? Now we'll come to ferritin. See, ferritin, it's serum ferritin. I'm not going into the details of serum ferritin, because when you go to serum ferritin, I have to know a little bit about what is stored ferritin and what is serum ferritin. For our discussion, we'll consider like this. See, ferritin is in storage form. Let's say that, and I said TABC is affinity, right? So let's say that you have had food. Just now you had food. I'm going to give you one more plate of food. Do you think you'll be having more affinity to eat the food? You won't have, right? On the other hand, I'm going to starve you for an entire day. I give you good food. Your affinity to binding the food and eating the food is going to be more. Same here. Serum ferritin and stored ferritin, duodenal ferritin are directly proportional, fine? So if my ferritin stored form reduces, my affinity towards binding to iron by transferrin increases. Obviously, my transferrin will be waiting for the iron to come and bind. If my serum ferritin or the stores is more, I have enough stores. Why should I go and bind to more and more? We won't, right? So that's how we are going to link my serum ferritin and my TABC. That's why I said as affinity. I'm going to compare these two, and these two are inversely proportional. Fine. So I'm sure the idea behind iron studies is clear now. So one, I have a directly proportional thing, and I have an inversely proportional thing here, right? So we'll have a look about my RBC protoporphyrin and my soluble transferrin receptors. First, we'll look at soluble transferrin receptors assay. Fine. We'll look at RBC protoporphyrin as well. Soluble or serum transferrin receptors both means one and the same. Okay. So I said that this soluble or my serum transferrin receptor is going to directly reflect the amount of transferrin receptors in the erythroid, right? That's what we saw. My body or my erythroid is not getting iron. There's no iron in the erythroid because there is no iron in the serum. Transferrin is not coming in binding to me. So I'm having less load of transferrin exposed to my erythroid. So what my erythroid will do is, it's thinking that, okay, the amount of receptor on my surface is less. Let me produce it more. So when there is no transferrin coming in binding to the erythroid with adequate quantities of iron, my erythroid functions too much and says that I'll increase the amount of transferrin receptors. So if I have more transferrin receptors in surface, there's an assumption that I'll be able to bind to even tiny quantities of iron present, right? That's logical. So in other words, in an iron deficient state, the amount of transferrin receptors on the surface of erythroid will increase. That's a feedback mechanism. If the amount of transferrin receptor on the surface increase, what do you think will happen to soluble transferrin receptor? That also will increase, right? That's all. I'm just going to write whatever we said. Soluble transferrin receptors is going to reflect the amount of transferrin receptor on the surface of erythroid. There is less iron, which means there is less iron in the serum, which means there is less iron in the erythroid for hemoglobin production. So as a feedback mechanism, what my body is going to do is, it's going to increase the transferrin receptors. When it increases the transferrin receptors, it's just to help you to say that, okay, my receptors is more, so that I will be able to bind to any tiny molecule of iron present, right? So if my transferrin receptors on the surface is increased, obviously it directly reflects my soluble transferrin receptors as well. This also will increase. So in iron deficiency anemia, where there is deficient iron, the amount of soluble transferrin receptor is going to increase. The normal value is 4 to 9 microgram per liter. It will definitely be increased. Right? Just for understanding, it's 4 to 9 micrograms per liter, and obviously in your iron deficiency anemia it will be increased. Okay, got it? Hopefully it is easier. We'll go to another new finding of serum free erythrocyte protoporphyrin. Fine. Again, protoporphyrin is nothing but a byproduct of iron, your heme synthesis, right? My heme, the outcome of heme is not there because iron is required for heme to form, but my heme synthesis continuously goes, right? When my end product is not there, that's normal thing in what you read in biochemistry. When my end product is not there, the substrate keeps on increasing, and all these intermediate steps will increase. So since my hemoglobin or my heme is not coming out properly because of deficiency of iron, the erythrocyte protoporphyrin keeps on increases, right? So my RBC or my free erythrocyte protoporphyrin, it again is just a feedback mechanism, will increase. will definitely increase in response to in case of an iron deficiency anemia, right? So these are the 6 things which I'm going to be totally relying on in iron studies. Based on that, we can easily say what's going to happen in different stages of iron deficiency anemia. There are a few more tests as well, like reticulated hemoglobin. We'll go when we have the complete workup of iron deficiency anemia, fine? So first, what I'm going to go here is we're going to see about the stages or phases of IDA. Okay, we have 4 phases of stages of IDA. The first one is your iron normal one, and second is your negative iron balance. The third I have iron deficient erythropoiesis, and the final one is my iron deficiency anemia. Okay. Normal, I'm not going to talk. You'll have normal amount of iron stores. Everything is perfect. My production of RBCs also is perfect. The second is negative iron balance. Let's say that when your bank account balance is negative, which means whatever I had savings is gone, right? Only my savings is gone. Will you say that when my savings is gone, my amount of I have taken everything from the bank, I'm having it for me to spend? That's what I know first, right? That's what we do first. When I have reduced cash in my pocket, I take from the bank and I utilize it. Same thing happens here. I'm not having adequate iron from the food. So first thing what I'm going to do is my hepcidin will hepcidin will decrease. Tell my ferroportin to give everything to my serum for transferring to bile. So the first thing which will get depleted is iron stores, right? So the first stage is negative iron balance. Okay. So when I say negative iron balance, there is reduced iron in the serum. So what I'm going to do is I'm going to absorb more iron from the stores. I'm going to absorb or use more iron from stores. When I use more iron from stores, my main goal is I'm going to make sure the serum iron becomes normal. That's my main goal. It will normalize automatically because I'm taking iron from the stores. So I have money in the hand or iron in the serum, but my stores are completely gone, right? So that happens in my negative iron balance. So this happens, once this happens here, I'm able to give decent amount of iron to my erythroid, and my erythroid is able to produce decent amount of RBCs. This is negative iron balance. In this, let's see what will happen to the iron studies, because all these are based on my iron studies only. See, this is like a compensatory mechanism, like a phase of compensation, right? Just a compensation phase. If my iron in the serum is reduced, I'm going to compensate from the stores. What do you think will happen to the serum iron total? Will it alter? Will it reduce? Will it be normal? It was reduced initially, but I compensated from my storage part, so my serum iron will be completely normal, right? So what happens here is serum iron will be, it's compensated. It was reduced obviously, but I can compensate it, so here serum iron is normal. In iron studies, what we saw was there is one person which is always directly proportional to serum iron. Who is that? Saturation. Perfect. So my transfer and saturation here will be normal again. It will not alter, it will be completely normal here, right? My transfer and saturation is normal, my serum iron is normal here. But my storage component has been taken, my iron from the stores has been removed, so my ferritin becomes low. Okay, so what happens for me is serum ferritin. Say I have not gone into much of depths about serum ferritin and storage ferritin. Ideal scenario is my iron, when it comes to my serum, 90% of them will go to transferrin, 10% of them will go to serum ferritin. So whenever my serum iron reduces, I'm going to take from the serum ferritin. So obviously serum ferritin will reduce. That's why we call ferritin as a very, very sensitive test. It's going to pick up very early. Very early, that's my first stage of negative iron balance itself. Serum ferritin will be altered. Fine. Again, for understanding, my normal serum ferritin is 50 to 150 micrograms per liter. Fine. It will be reduced. So we had one iron study which was indirectly proportional or inversely proportional to my serum ferritin, which is total iron binding capacity, right? When my serum ferritin reduces, what do you think will happen to iron binding capacity? Perfect. TIBC will increase, right? Again, for understanding, the normal TIBC is 300 to 360 micrograms per deciliter. Fine. This is the normal TIBC and it will increase. So these are the only changes which happens in the earliest phase, right? My serum ferritin will reduce and my TIBC will elevate. Okay, that's what is going to happen in my normal first phase of negative iron balance. Other findings of my bone marrow iron more or less will be normal. If my iron in the bone marrow is normal, the sideroblast will be normal again in the bone marrow. RBC erythrocyte protoporphyrin is completely normal. See, because here once negative iron balance only, nothing has happened to bone marrow, so protoporphyrin will not change. Everything is formed completely normally, right? My soluble transferrin receptor will not change because my erythroid has not felt the burn yet. In the next phase only it will feel it, fine. So everything else is normal. The only person to change is these two. Everything else is my RBC protoporphyrin, your soluble transferrin receptors, your bone marrow iron stores. Everything is more or less normal. I am able to compensate whatever I have lost, whatever is deficient in the serum. From my stores, I am able to compensate that. There is no other problem at all. Fine. So if I know this is going to happen in the first phase, the second phase is understood. Here I was able to compensate. The second phase, my compensation fails. And otherwise, I have used up everything in the stores. I don't have anything. So my serum iron reduces, right? The second phase, I'm going to call it an iron deficient erythropoiesis. I'm going to call it an iron deficient erythropoiesis. When I say an iron deficient erythropoiesis, here the iron amount in the serum is reduced. Fine. So when iron amount reduces, can I say that the saturation of transferrin will reduce? It will reduce, right? Transferrin has not completely saturated. It's taking partly saturated transferrin to my erythroid. If that happens, will my erythroid get enough iron? Bone marrow iron stores, lost. Marrow sideroblast, lost. Everything gone. Iron is not there in erythroid. Can they produce good amount of hemoglobin or heme? No. When they can't produce good amount of hemoglobin, what will happen to RBC protoporphyrin? It will increase. So all this happened. My erythroid is in state that I need little bit iron, please give me. So what it will do? It will increase my surface transferrin receptors. So what will happen to soluble transferrin receptor? It will also increase. Whatever happens here, RBC morphology will not change. It's just iron deficient erythropoiesis. The only thing which will be normal here is RBC morphology. That happens to the last. Fine. So what happens here is not able to compensate the loss. Maybe a decompensatory phase, that's all. If I'm not able to compensate, my serum iron will reduce. If serum iron reduces, the person who's going to be directly proportional to that is saturation of transferrin. That will obviously increase, right? Sorry, that also obviously will reduce. They are directly proportional, right? See, in the first stage, we had marrow, iron stores, serum ferritin, TIBC, everything altered. Here also those will be altered, fine. My serum ferritin will be reduced. My TIBC will be increased. Marrow, iron stores will be gone. Okay. You'll have marrow sideroblast will be reduced. Sideroblasts are nothing but the erythroid which has good quantities of iron, which means that can give for hemoglobin production. The amount of sideroblasts in the marrow reduces. Normally marrow sideroblasts will be 40 to 60% in a normal person. Here it will reduce significantly. Fine. My RBC erythrocyte protoporphyrin will be elevated. Same will be my soluble transferrin receptors. That also will be elevated. The only thing which will be normal here is normal RBC morphology. My RBC morphology will be completely normal in this patient, right? I hope there is no doubts in this stage, right? Everything is going to be completely normal here. The only abnormality what I'm going to find here is, only normal thing what I'm going to find here is my RBC morphology. Everything else is going to be abnormal, right? So my second stage. After that, what happens is, I'm not able to compensate. I'm not able to produce good amount of hemoglobin. So when it progresses, the only thing I'm going to have is, it will automatically cause an abnormal morphology. My RBC will become microcytic, RBC will become hypochromic as well, right? That I'm going to call them the third stage of an iron deficiency anemia. Here everything will be altered. all the above findings will be there, which is, I'll just write iron deficient erythropoiesis findings plus microcytic hypochromic anemia. Fine. Now, microcytic hypochromic anemia as well, right? Those are things which are going to happen in my iron deficient anemia in the terminal stage of iron deficient anemia, right? So we know the pathogenesis. We link the pathogenesis with the iron studies, right? We need to know about it because it's a continuum, right? So I know about the pathogenesis, I know about the etiology, I know about the iron absorption. The only thing what we require is we need to know about what's going to happen in the patients clinically. If I'm going to know what's going to happen in the patients clinically, I should be able to diagnose the patient and hopefully I'll be able to treat the patient as well, right? That's our next goal. So first, as I said that I'm not going to depths of clinical findings. Like with any anemia, what I'm going to have is pallor. See, pallor will not change, fatigue will not change, tiredness will be there. That's a common finding in any anemia. See, almost entire RBC as well as WBC doesn't have like very specific clinical symptoms, right? I have lymphoma, lymphadenopathy, anemia, fatigue, pancytopenia, petechiae, hemorrhage. So entire workup is going to be based on my lab diagnosis only. The algorithm is completely based on lab for almost entire hematology. I have few clinical clues, very classical clinical clues. I am sure you know that the koilonychia, the spoon-shaped nail. There's a reason for that also. It is the nail bed capillaries. The nail bed capillaries doesn't get enough oxygen because of the deficient hemoglobin. So this growth rate will get altered. So whatever nail comes out, it's not perfect, it becomes spoon, right? It becomes concave. That will be very well explained in your dermatology textbooks. I know the dermatology educator must be able to clear that, fine. So one very specific finding for me is koilonychia. This is a spoon-shaped nail. Okay. This is due to the altered oxygen levels concentration to the nail bed changes, and because of that an altered growth of the nail. Fine. Second, I have Plummer-Wilson syndrome. This is kind of an association. You have an esophageal webs. An esophageal webs plus your iron deficiency anemia. There's no strict connection between those. It's just an esophageal web formation with an iron deficiency anemia. We call it Plummer-Wilson syndrome. That's all. Fine. It's an association study than having a direct etiology of why esophageal web is present in case of an iron deficiency anemia. We are not exactly able to identify that. Fine. So with the clinical findings, I'm going to suspect an IDA. When I'm going to suspect an IDA, I'm going to do the test. Right. Every RBC disorder has the same protocol: CBC, peripheral smear, specific serological test, bone marrow examination if required, any ancillary testing of genetics or your flow cytometry if required, and I'm going to come to a confirmatory diagnosis. Here also same. The lab protocol is very, very important. You're going to see what are the lab changes is going to be there in iron deficiency anemia. The first thing here will be your CBC. There are lots of finding in my complete blood count. So in complete blood count, MCV will obviously be reduced because you're microcytic. When I say reduced, it should be less than 80 femtoliter. Anywhere it's going to be less than 80 femtoliter, I'm going to call it a microcytic anemia. It can be 50 or it can be 78, doesn't matter. Anything less than 80, I'm going to call it a microcytic anemia. Again, there are many differential diagnoses for microcytic anemia. One of the leading causes my iron deficiency anemia. Fine. Now, MCH, it's hypochromic, right? Less than 27 picogram. Right? Less than 27 picogram, I'm sure that the amount of hemoglobin concentration in the RBC is reduced, so that will be seen in microcytic hypochromic anemia. That's my normal dictum. Fine. When I take microcytic hypochromic anemia, I'm saying MCHC. There's one very common differential diagnosis, that is my Tal minor. Tal minor is a very, very common differential diagnosis of an iron deficiency anemia. Clinically as well, low grade anemia in between, it's not very severe. And on my MCV, MCH also, it's a very close differential diagnosis. So the same machine of CBC, the hematological analyzer, will be able to give an parameter which will help me to differentiate my iron deficiency anemia from a thalassemia minor. Right? That parameter is, you have something called an RDW, called as red cell distribution width. Okay, red cell distribution width is important from an MCQ point of view. It has been asked previously. we'll try to understand RDW so that we'll be able to apply it whenever anything comes. See, understanding of a concept is not to answer the older questions. If any new questions comes on the same concept with a different application, we should be able to solve them as well. Fine. So let's say, what is an RDW? RDW, nothing but it says the degree of anisocytosis. Okay, just going to tell me the degree of anisocytosis. Just the degree of anisocytosis, that's all. That has come in an AIMS exam once. It's just the degree of anisocytosis. So we'll look at an example. What does the degree of anisocytosis means and what is a normal RDW, and then it will be easier for me to identify what happens in IDA and the other close differential diagnosis of thalassemia. Fine. So let's say that a person's MCV, normal MCV, the range is 80 to 96 femtoliter. That's what I said, that less than 80 is microcytic, right? The normal MCV is 80 to 96. So this is the range. I can have 80, I can have 96. Still that it's normal. So RDW is the range. So RDW is said as, let's say, 14 to 16. The gap, the number of units between 80 and 96, maximum 16. So I'm going to call it as 14 to 16. That is normal RDW. Fine. It's completely normal RDW. Fine. There are two ways to express RDW. The common way expresses 14 to 16 is easier to understand as well for me. Fine. So now let's take, with this, I'm going to consider the two differential diagnoses of iron deficiency anemia and thalassemia. Okay, we're going to consider ID and thalassemia here. See, let's give an example. Iron deficiency anemia is a nutritional problem, right? Let's say that a person is iron deficient today. I'm not having enough amount of RBC stores, so nothing has happened. I eat good amount of food for the next 1 week. My stores is kind of replenished. My erythroid is able to produce good amount of RBCs. Maybe 1 week, 10 days. I got a good food because from hostel I came to my home. So during the 10 days or sometimes after the 10 days, the number of the shape of the RBC and the size of the RBC produced will be normal. Yes. In other words, can I tell the ID as a dynamic pathogenesis? It has to be a dynamic pathogenesis, right? Which means there will be variation. That's what dynamic means. It's not always less, it's not always high, it will be fluctuating. With dynamic pathogenesis, the amount of iron will also fluctuate. When the amount of iron fluctuates based on the intake, the amount of RBCs produced can be normocytic as well as can be microcytic. Clear? It could be possible to have both normocytic and microcytic RBCs, right? This is what happens in IDA, which means I'm just giving you an example of MCV. It could be from 80 to 96, that is normocytic, and just for our argument's sake, we'll keep microcytic as, let's say, 65 to 80. Okay, 65 to 80 for microcytic. Now tell me the RDW. The range here, the lowest one is 65, the topmost one is 96, which means my RDW is greater than 30. Is it wider than the normal? Absolutely right. It's very much wide. It's very much wider than the normal RDW. Fine. So this is what happens in my iron deficiency anemia. It's a very dynamic pathogenesis. Let's consider thalassemia. See, we're going to take thalassemia. Thalassemia is a nutritional problem or a problem in the genetics. It is a genetic abnormality, right? So thalassemia is absolutely a genetic abnormality. When I say it's a genetic abnormality, it's the food intake is not going to alter the production of RBCs, which means permanently thalassemia patients will have microcytic RBCs only, correct? Yeah, they are always going to they can produce only microcytic RBCs. They can never produce normocytic cells because nutrition will not change it. Not even nutrition, no treatment will change it. It will always be the same, fine? Which means here, again, I'm just, for argument's sake, I'm putting MCV as 65 to 80, which means my RDW is approximately 15. Fine. The gap between them, the range between them is 15. Fine. So here my RDW is normal. Got it? So why we came into the discussion is both iron deficiency anemia and thalassemia was microcytic and hypochromic. A simple finding of RDW can make me come to a conclusion that iron deficiency anemia, my RDW will be more, and with thalassemia, my RDW will be normal, right? This is a conclusion which is common in exam. If I know this, can I extrapolate saying that not just iron deficiency anemia, all nutritional anemias will be the same? The alteration RDW, it has to be, right? So for megaloblastic anemia also RDW will be elevated. That's what I'm going to apply concepts to. Any nutritional anemias, whatever I know, my RDW will be wider. Genetic deficiencies, RDW will be constant. Got it? Great. So these are the informations which a CBC can give. One more finding in platelets. Platelets will have reactive thrombocytosis. Okay. Again, this is a very common finding seen in IDA for unknown reason. We are not able to yet elucidate why this is happening, but it's a common finding. So we have any patient with a more WB platelet count, the first thing you have to look for is check for IDA, iron deficiency anemia, right? So we know what all findings you can see in CBC. Now we'll go to peripheral smear. When you go to peripheral smear, first I have to identify it is microcytic or not. Then I have to identify whether it is hypochromic or not. See, when it's an CBC value, I know value. It will be given by the machine that it's less than 80 and it is less than 27. It's very easy to call it microcytic and hypochromic. In a real life, how I'm going to look at the image? I'm going to compare with the other cells. A normal RBC will be the size of the nucleus of a small lymphocyte. Fine. When I call something microcytic, it's going to be smaller than nucleus of small lymphocyte. Okay, it's going to be smaller than the nucleus of small lymphocyte, then it is microcytic. I'll call something as hypochromic when the central paler, again the central paler, the normal is 1/3. If it's greater than 1/3 central paler, I'm going to call it a hypochromic RBC. Fine. That's how I determine it's a microcytic and a hypochromic RBC. There are very few classical cells. You will have anisopoikilocytosis. There will be variation in the size of the RBCs and the shape of the RBCs as well. And also a very, very classical finding called pencil-shaped RBC. Pencil-shaped RBC is almost diagnostic of iron deficiency anemia. If you have any question with saying that pencil-shaped RBC is seen, think of iron deficiency anemia as the diagnosis, right? Because it's very, very specific for an iron deficiency anemia. Okay, so just have a look at how we are able to confirm these findings. Fine. You have few images here. Okay, see, this here is my small lymphocyte, right? This is small lymphocyte. Definitely, this is definitely smaller, undoubtedly smaller, right? There are many things which are smaller, right? At the same time, I can also see well hemoglobinized RBC, normal, right? This explains my RDW. I have lots of variation in the size. I have normal cells, I have smaller cells, I have very tiny cells. And we look at these, whatever I'm marking, it's undoubtedly hypochromic. The central pallor is easily greater than the central 1/3. I have hypochromic RBCs, I have microcytic RBCs, so my first diagnosis is going to be an iron deficiency anemia, right? Now look at this. And look at these. These are my pencil-shaped cells. Those are my pencil-shaped cells, right? One of the very close differential diagnosis of a pencil-shaped cell is an elliptocyte. You have to be able to differentiate them. The easiest way to differentiate them is look at the pallor. A pencil-shaped cell should be pale. Okay, it should be pale. That's a way to differentiate it from an elliptocyte. You must have read about hereditary elliptocytosis. Hereditary elliptocytosis, the elliptocyte also will be elliptical like this, but they won't have a central paler. This will have a central paler, right? So I'll be able to easily differentiate my pencil-shaped cell from an hereditary elliptocytosis. Okay. So I know how to identify them on a microscopy. So I identify them on a microscopy. My CBC also says that it is definitely looking like an iron deficiency anemia with the help of RDW and everything. Again, I cannot write as iron deficiency anemia unless I am able to confirm it, right? So confirmation is almost always by serology. Serology includes my iron studies, the same 4 iron studies, right? Serum iron, I'm going to just write it faster. Serum iron will be reduced, right? Serum iron will be reduced, serum ferritin will be reduced. Serum ferritin is the most sensitive test for IDA. There's a specific test, I'm not going to mention it, which is bone marrow iron stores. No one is going to do a gold standard way of diagnosing IDAs. Bone marrow iron stores, no one is going to do a bone marrow biopsy for sure, fine. Serum ferritin is reduced. Transferrin saturation is directly proportional to serum iron, is reduced. My TIBC is inversely proportional to serum ferritin, is elevated. RBC free erythrocyte protoporphyrin will be elevated. Soluble transferrin receptors will be elevated, right? Actually, these four are the ones which are commonly available. Most of the time diagnosed based on the first four only. Other two are just for theoretical application. In real life, we don't encounter people asking for erythrocyte protoporphyrin or transferrin receptors. It's more of a theoretical importance, and for diagnosing and managing a patient, the first four values are more than important, more than enough for me, fine. I do have something called as a reticulated hemoglobin. I'll look at that soon, fine. Because reticulated hemoglobin is a new finding which might come in your exam, which is useful for my follow-up as well as my diagnosis, right? We'll have a look at them soon, fine. So I know it's a diagnosis of an IDA. So treatment is extremely simple. I'm going to treat the patient with iron tablets and supplements. I'm going to leave the treatment to you guys. The only two things I want to tell is treatment of IDA is simple, at the same time bit complicated. You need a counseling, because patients who are having an iron deficiency anemia, when you give an iron supplement, they'll take it. There are two main side effects, which is your gastritis and black tarry stools. You should convince the patient that black tarry stools is normal and tell the patient gastritis is unavoidable. There are few newer generation iron supplements that has a less incidence of gastritis, but still they'll have gastritis, right? The easier way to make sure gastritis is reduced, incidence reduces, take the iron tablet with the food. The absorption will be reduced for sure, because the food will interfere with absorption. But something is better than nothing, right? Because when you don't take care of that, patient will not be compliant for iron, right? So compliance is the biggest problem in treatment of iron deficiency anemia. Once you treat iron deficiency anemia, I need to know whether it's working or not. It's a very important question, right? It's working or not. I cannot wait for my hemoglobin to rise. It'll take 3-4 weeks for my hemoglobin to rise. So it's not a very sensitive indicator. So tell me, my body iron's bone marrow is not having good amount of iron, and I have given iron. Will the bone marrow start functioning at a very rapid phase first? Yes. If my bone marrow functions, the first person who's going to get elevated is my reticulocyte count. So what I'm going to do is, there are few things saying that your Nelson has a table which comments on the amount of enzymes, intracellular enzymes in the cell will increase. That's the earliest finding. See, it's based on what I'm able to do in my real life, right? I will not be able to assess the amount of enzymes in the cell when I'm going to assess the response of iron deficiency anemia, right? So we'll go with practical application of what I'm going to use for the response. It's working or not is the response assessment, right? The first thing, obviously, the patient's subjective improvement. As I said, it's subjective. Some of the patients, when they see the doctor, they'll feel better, right? So patients might not be the ideal way to judge whether it's working or not, but yes, patient's importance is very, very important. Whether the patient is feeling better or not, it's very, very important for the clinical assessment and the judgment, right? Second thing, yes, amazing elderly, that is right. And IRITA, due to temperance gene mutation, it's like when you see 1,000 cases of iron deficiency anemia, you might see 1 case. So the incidence is like 0.1%, right? So we are going to complete all these common ones, and then maybe if time permits, we'll compare the DMT1 deficiency and the TMPRSS6 gene deficiency as well, fine? Okay. So what I'm going to do is, at 5 to 7 days post-treatment, okay? So 5 to 7 days post-treatment, the main thing what I'm looking at is, you're going to look at your increase in my reticulocyte percentage. When my retic percentage is increased at the end of 1 week, which means the patient is completely taken the tablet and is also responding to it. Like Amazing Elderly said, that if the patient is compliant and it's not responding to oral iron, I have to think of these rare entities. Gastrectomy might not respond. right? So I have to keep that in mind also, because that's more common than my mutations. There are few mutations where it's not will not respond to oral iron. There the only way is to give parenteral iron, right? We might look at the genetic variants of iron deficiency anemia sometimes later. Okay, so I do have an early detector, early finding, and a better finding than my reticulocyte counterpart. Right? That's called as an reticulated hemoglobin. See, reticulated hemoglobin is not a finding which can be seen on a microscope. It's a finding which should be given by the counter, the machines. So what does reticulated hemoglobin means? I'm not just assaying the reticulocytes. See, I'm giving iron to my bone marrow, it is producing increased reticulocytes. But I'm also worried about whether the reticulocytes formed have good amount of iron or not, right? So that's very, very important for me, right? So what does reticulated hemoglobin give is, it gives the percentage of hemoglobin in the reticulocytes. There's a counter value. If the percentage of hemoglobin reticulocytes is elevated, then I can perfectly say that I'm giving iron and it's responding as well. The normal range is around 29 to 33 picograms. If it's elevated, it's good for me that the patient is having a response, fine. Okay, there's a better indicator than just having a random retic count. Okay, so these are few things which I'm going to use for the follow-up in case of an iron deficiency anemia. Okay. Got it? So what we have seen today is we have just discussed about IDA, right? So we saw about the normal iron metabolism. Let's have a quick whole look of whatever we saw. We saw about the normal iron metabolism, how it's getting metabolized. Then we went about the etiology of iron deficiency, your chronic blood loss or your menorrhagia or increased demand. Then we saw about the normal iron studies, the traditional 4 ones, and we had a look about serum transferrin receptor as well. We know what is the serum transferrin receptor, why it is going to be changed, and how it is going to be altered in case of an IDA. That's one thing. And when we saw the stages of iron deficiency, the first stage obviously is being normal, the negative iron balance, iron deficient erythropoiesis, and also have iron deficient anemia. The negative iron balance, only ferritin gets altered. Ferritin means my TIBC also, rest everything is completely normal. Then I have iron deficient erythropoiesis, everything is gone except for my morphology, that keeps maintaining normally. The last one is IDA, where morphology is also altered. Then clinically there are few clues for me to diagnose IDA. Then CBC, we had a look about RDW, and then we also had reactive thrombocytosis and how to pick up my microcytic hypochromic anemia in a microscopy. Then serological studies, and then we went to treatment and the follow-up. Fine. So that's for today, and you can download the Unacademy app, and there are free tests for your medical PG entrance exam. This is the test for this week, and there are few batches starting for your upcoming NEET 22. Hopefully that happens in the March. Okay, and this will be the schedule of study with me. Today we had seen about IDA. We'll see tomorrow at 5 PM about RBC. Wednesday, Thursday again we'll be seeing about WBCs. If you want any particular topic to be covered in detail, do let me know in the Instagram or in the Telegram group. So I'll be able to handle that, because all these are going to be focused on these 4 days, and there'll be a test followed up in the Unacademy app based on the same topics, right? Based on RBCs and WBCs, right? Okay, that's for today. Thank you for watching. See you soon and tomorrow at 5 PM. Till then, bye. See you. And today evening we have a special class based on competency-based curriculum. If you're a second year MBBS graduate, the NMC has released a totally new curriculum, and they are given 2 sample papers. We'll try to solve the sample papers in today's class. Fine. Thank you. Bye-bye.